Yeah, yeah, very, yeah, very good evening, Dr. Pradeep and the Torrent people and my dear professional colleagues. And it gives me immense pleasure that Torrent people have given me the opportunity to be the speaker of this evening to talk about the fixed dose combination of the SGLT2 inhibitor, the Dapagliflozin, and the DPP4 inhibitor, the Sitagliptin. So let me start my talk with this. The diabetes treatment in India, the need of novel fixed dose combination, the SGLT2 inhibitor with a combination of the DPP4 inhibitor. Next slide, please. This slide very clearly shows us the global burden of the diabetes mellitus. You can see on the extreme left, you can see the incidence of this thing, the global burden in North America and the Caribbean islands is 51 million patients of this thing suffering from type 2 diabetes mellitus. And you take the South and Central America, it is 32 million. And you take the Middle East and North America, it is 73 million. When you take the European continent, it is 61 million. And you take the Western Pacific population, that is 206 million. And the African continent, you take, it is 24 million. And the Southeast Asia with 90 million respectively. This is from the records of the Diabetes Atlas, that is the 10th edition, that is from 2021. Next slide, please. So, the affected Indian population with diabetes. Now, this picture shows. It says that 74.2 million people are suffering from diabetes in India, and some figures. This is also taken from the International Diabetes Federation Atlas, Diabetes Atlas 10th edition, that is 2021. According to our statistics, I think it's around some 77 million people are suffering from diabetes mellitus as far as India is concerned. And 1 out of the 7 diabetic patients in the world is an Indian. And 39.4 million people, that is somewhere around some 53% of the adults in India are underdiagnosed, and 1 in 12 adults in India is suffering from diabetes. So this is supposed to grow in abnormal proportions in the coming years, like 2030 and 2040, as the projections are very high. And as of now, the entire world is if you take the entire global population of diabetes, it is around some 440 million actually. Next slide, please. And let's come to the diabetes scenario in India. The unique features that we find in our Southeast Asian continent, that is Indian subcontinent. The type 2 diabetes starts at an younger age in India, at least 10 to 20 years prior to that of the Westerners. And when the diabetes starts very early, the complications also start very early. The Indians have got low beta cell mass and high insulin resistance. And in contrary to this second statement, now the latest research shows that even the Indians, apart from the background pathology of insulin resistance, we are finding the insulin secretory defects also. So earlier we used to think that a obese type 2 DM patients, they just walk into our chamber. We used to think that insulin resistance is the prime pathophysiology behind this particular obese type 2 patients. And now it is very clearly shown that apart from this particular insulin resistance and low beta cell mass, that is the reason why the low beta cell mass that leads to the insulin secretory defects. So we find even this insulin secretory defects quite often in type 2 diabetes in an Indian scenario. And micro and macrovascular complications appear early in the Indians. The same reason, because it is diagnosed early, it starts early, type 2 diabetes starts early, 1 to 2 decades early when compared to the Western population. So almost the micro and macrovascular complications also appear early in the Indians. That is, the microvascular complications, the incidence being 52.1%, and the macrovascular being 29.7% respectively. And 1 in 3 patients with diabetes will have early onset of cardiovascular disease. Cardiovascular disease is nothing but it's a combination of either the myocardial infarction or stroke or both. And only 36% Indians achieve good glucose control. This is very pathetic. And I think in reality, even this is a good figure actually. Even less than this are to the good glucose control actually. And the coronary artery disease accounts for more than 80% of all deaths. That is, actually the coronary artery disease or the cardiovascular disease accounts for 86% of the all deaths and 75% of all hospitalizations in diabetic subjects in our country, the Indian scenario. Next slide, please. Yeah, now we can see this, the Indian diabetics, the early progression with multiple comorbidities. On the left hand side, you can see the high prevalence of vascular complications which are seen in the Indian type 2 diabetes mellitus patients. Type 2 diabetes mellitus onset in Indians is nearly 2 decades earlier than the Western scenario. And the microvascular complications and the adult type 2 diabetes, especially that is with reference to the people who are below the age of 40 years, it's the incidence is like neuropathy is 17.7% of the patients, they do suffer from neuropathy. 13.7% of the patients, they do suffer from retinopathy, and 18.2% in early adulthood they have nephropathy. And from 2016 onwards, the American Diabetes Association has abolished this term nephropathy and they replaced by a term called diabetic kidney disease for a better idea over that particular the diabetic kidney disease as far as the healthcare providers and the healthcare professionals are concerned. And this is the scenario of the patient suffering from type 2 diabetes of less than 40 years only. You can see the incidence, and the incidence moves up and it goes up as the age increases actually. That is like as the age increases, the general incidence of neuropathy is somewhere around some 30 to 50%, and retinopathy, that is the commonly seen complication in every type 2 diabetes, that is to a tune of 96%, and the diabetic kidney disease, that depends from 30 to 40% in any given age. And on the right hand side, you can see the increased burden of cardiovascular risk, and you can see the blue lines actually, and this is the y-axis shows the years actually, and the first one is normal, and the second blue bar is the impaired glucose tolerance plus diabetes. The prevalence of coronary artery disease is 18.6%, and moving on to the third one, the impaired glucose tolerance plus the diabetes plus hypertension, the risk goes up by 21.2%, and the impaired glucose tolerance plus diabetes plus hypertension plus dyslipidemia, that is the diabetes along with the comorbidities like hypertension and dyslipidemia, the incidence of the prevalence of coronary artery disease still goes up by 25%. See, this slide shows us the very importance of pre-diabetes, that is which is either the combination of this particular impaired fasting glucose or the impaired glucose tolerance or sometimes the combination of both. So the importance of prediabetes is the cardiovascular disease, the incidence of coronary artery disease in prediabetes is at par with the coronary artery disease in overt type 2 diabetes, so that we have to screen the patients, catch up the patients at the stage of impaired fasting glucose or impaired glucose tolerance, or combined, put together both, which is called this particular prediabetes. So prediabetes, we need to catch up early, and lifestyle modification is mandatory, and initiation of metformin is mandatory as per the American Diabetes Association, the recommendations. But very pathetic scenario is that only 3% of the patients diagnosed with pre-diabetes are receiving metformin all over the globe. See, another 97% who require, apart from lifestyle modification, they are not receiving the metformin as a protocol and as per the recommendations of the American Diabetes Association. So it's high time we need to start the non-pharmacological therapy as well as the pharmacological therapy with metformin for all the cases of the prediabetes to prevent the complications actually. And the inference is the micro and macrovascular complications appear very early in the Indian patients, because type 2 diabetes itself comes very early, that is 1 to 2 decades earlier when compared to the Western scenario. Next slide, please. Say, what should be the aim of type 2 diabetes management in Indians? Next slide, please. Yeah, the aim is to control diabetes, prevent its complications, and increase the lifespan. So here I would like to add, like I do it in every speaker program of mine. See, the aim is not to control mere diabetes. All the time remember ABC. See, when you are able to control all the three, the A1C and the hypertension, the blood pressure and cholesterol, then only you will be able to prevent the complications and increase the lifespan. So here we are focused to the diabetes. So aim is to control diabetes, also control blood pressure, also control the dyslipidemia, and prevents its complications and increase the lifespan. So the first one is the prevention of the microvascular complications. So the very peculiar feature of microvascular complications is that the three microvascular complications, either the retinopathy or the neuropathy or the diabetic kidney disease, are the glucose control dependent complications. So if you can maintain a very good glucose control, so you can almost control this particular microvascular complications. And this is the peculiar feature with microvascular complications. They go parallel with the glucose control. Can you please can the audience please mute themselves? I'm not able to concentrate because I'm getting the noise. Please mute all. Okay. So the prevention of microvascular complications like retinopathy and the neuropathy and the diabetic nephropathy. And second thing is the macrovascular complications, especially the coronary artery disease and the stroke and the peripheral vascular disease, because these the peculiarity of these macrovascular complications are not totally dependent upon the glycemic control, because there are several other risk factors which come into play when these macrovascular complications are concerned. So microvascular complications are totally dependent on the glycemic control. So each 1% of reduction in the A1C results in so and so reductions in the retinopathy and the neuropathy and the diabetic kidney disease. Whereas it is not so with the macrovascular complications, because macrovascular complications, especially the coronary artery disease and the strokes and the peripheral vascular disease, there are several multiple risk factors, not only diabetes. it's hypertension, it's dyslipidemia, it's smoking, it's alcohol, the sedentary lifestyle, and the obesity, especially the grade 1, grade 2, and the grade 3 morbidly obese patients, and the family history of heart attacks and strokes that plays a vital role, and the lipoprotein little a, that is the one another important. So there are so many risk factors apart from the diabetes. So this becomes the control of this particular the macrovascular complications is bit difficult unless you go for a multi-pronged approach to counter all the problems, all the risk factors which cause this particular macrovascular complications. And finally, the relief from the symptoms of the diabetes and improvement in quality of life. This is the basic expectation of the clinician as well as the patient also expects some sort of relief. Suppose the patient has got polyuria, polydipsia, polyphagia, loss in the weight, unexplained weight loss. So he finds some relief from the symptoms. And most of the times in our Indian scenario, the diabetes, the type 2 diabetes is diagnosed with one complication or with one symptom, like either the nocturia or the balanitis or fasciitis or balanopasciitis in the males, or the vasinitis, the vulvovasinitis, the candidial vulvovasinitis in the females. Likewise, we need to take a good history before diagnosing the patient. And the increase lifespan and the improve quality of life depends on this particular aspect of preventing the complications and increasing the lifespan. Next slide, please. Yeah, these are the clinical challenges in managing diabetes. See the early start of diabetes, and you can see the limitation of the current treatment approach for preventing the development of macrovascular complications. And you can see the multiple studies. The United Kingdom prospective diabetes study and the ACCORD, that is the action to control the cardiovascular risk in diabetes, and the advance, that is the action in diabetes and vascular disease, pre-TERAX and diamicron MR controlled evaluation, and VADT, that is Veteran Affairs Diabetes Trial, and the DCCT and the EDIC. DCCT is the Diabetes Control and Complications Trial, which was exclusively done in the type 1 population. It's a landmark trial actually, and the EDIC is the follow-up trial of DCCT. We call it the EDIC, that is the epidemiology of diabetes interventions and the complications. And once we come to this, the UKPDS, you see this the baseline A1C versus the control, the control versus the intensive. That is, you find the baseline A1C in UKPDS as 9, and you can see the difference between the control versus the intensive glycemic control. That is, 9% has come down to 7.9 in the control versus 7% in the intensive control. And the mean duration of diabetes at baseline, the UKPDS, that is the landmark trial still which is going on, which started in 1977, the United Kingdom prospective the diabetes study that included all the newly diagnosed patients. And you take the microvascular incidence, the incidence are reduced with the reduction in the A1C from 9 to 7%. And you take the cardiovascular disease, it is neutral because it is, I told you, the type 2 diabetes, the glycemic control, these are not the only one to determine the cardiovascular disease, that is either the coronary artery disease or the strokes, and the mortality is also neutral as per the UKPDS. And when you take this particular ACCORD, the advance and VADT and the DCCT and EDIC, you can respectively see that the A1C baseline in ACCORD from 8.3 has gone to 7.5 in the control group versus the 6.4 in the intensive group, and the mean duration of diabetes is 10 years, and you find a reduction in the microvascular. The very peculiar feature of this particular all the studies is there is a definite decline in the incidence of the prevalence of the microvascular diseases in all the UKPDS, ACCORD, Advance, VADT and DCCT and EDIC. The only thing is the cardiovascular disease, it remained almost like neutral, and the mortality was increased very surprisingly in ACCORD, others where it was a simple neutral one, and barring this UKPDS and VADT, they had shown the positive impact of tight glucose control on cardiovascular disease and mortality in the long term. So next slide please. So this slide shows us the diabetes related complications that appear early and accumulate rapidly in 60% of the participants despite the background therapy. So on the left hand side you can see the total study that was published in the New England Journal of Medicine in 2021. The largest therapeutic trial in the adolescents with type 2 diabetes mellitus, more than 500 participants with a mean age of 24.4 plus or minus 2.8 years, and time since diagnosis is 6.3 years plus or minus 1.8 years. And you always have to remember that the type 2 diabetes mellitus is always a progressive disorder. And if you follow this the bar diagram very carefully, and the bottom line, that is the A1C, that represents the A1C of less than 7.5, and the top one that represents 6.5 to 8 of A1C, and the green color that corresponds to 8 to 10% of A1C, and the yellow one is around or more than 10% of the HbA1c. Now we can see from the baseline where when the patient progresses on to 15 years, you can find in the beginning 75% they have the A1C of less than 6.5, and the 25% had 6.5 to less than 8%, and after 3 years the A1C group, which was in 75%, has drastically fallen down to 46, and after 6 years 28, after 9 years it is 28, and after 12 years it is 20, and after 15 years it is only 19% of the participants were able to maintain the glycemic control. So, and this after 3 years you take this 43 and 17 and the 16 and the 20 has become the 28, 17, 18 and 37 after 6 years, and after 9 years it has become 28, 10, 17 and 45 respectively, and after 12 years of duration it has become the 20, 16, 18 and 45, and after the end of the study, that is the today's study, the 15 years it has become very suboptimal, that the 75% of the participants who were maintaining a very good glycemic control with an A1C of less than 6.5 has come down to only 19%, and 6.5 to less than 8 has become only 21%, and from 8 to 10% it has become only 25%, and above 10, around or above 10 is 34%. And we come to the left hand side, and you can see the different graphic representation. The first one being the hypertension, the second one being the kidney problems, and the third one the dyslipidemia and the nerve disease, that is either neuropathy, whatever it may be. So at the baseline, if you take the hypertension, you can clearly see that the incidence, the basic baseline prevalence was 19.2, and the cumulative incidence after 15 years it is 67.5%. See the erroneous and the erratic growth in the prevalence of hypertension when compared to the cumulative incidence after 15 years. Likewise, you take the kidney parameters, and the baseline prevalence is 8%, and the cumulative incidence after 15 years it is 54.8%. And you take dyslipidemia, respectively, the baseline prevalence was 20.8%, and the cumulative incidence at the end of 15 years was 51.6%. And the nerve disease, the baseline prevalence was 1%, and the cumulative incidence after 15 years was 32.4%. So, I once again tell you, the type 2 diabetes remains always a progressive disorder, and the glycemic control remains very suboptimal if it is not addressed properly. Either to start with the non-pharmacological methods, that is lifestyle modification, diet and exercise, and the comprehensive form of the lifestyle modification, that is the therapeutic lifestyle changes, that is the diet, exercise, reduction in the weight, cessation of alcohol and cessation of smoking, along with the appropriate drugs. See, I tell you, one size doesn't fit all, because you need to have the individual counseling to the patient, and you should have the individual the prescription for that particular patient, what suits best to that particular patient. So all the time remember, one size never fits all. Next slide please. Now coming to the role of the DPP4 in the Indian context. The greatest advantage of this DPP4 inhibitors or the SGLT2 inhibitors. The DPP4 inhibition is maximum in Indians and the Asian population when compared to the Caucasians, actually, because the reason is very simple, that the DPP4 inhibition is maximum in Indians and Asians when compared to the Caucasians, the whites. So we have a better glycemic control in terms of the better fasting plasma glucose, and overall the better A1C controls, which is seen with this particular, say now we are referring to the particular molecule Sitagliptin, the most potent out of all the gliptins. Actually, this is the second gliptin to be introduced in the globe. Actually, Vildagliptin was the first one, Sitagliptin was the second one, and the Saxagliptin was the third one, and later on came this the Linagliptin, and so on. So when you take this the parameters, the fasting plasma glucose and the HbA1c controls in Indians with regards to the Sitagliptin, because of the better DPP4 inhibition, so you find the A1C in all the countries like placebo and Sitagliptin, the number you can see is 169 versus 339, and in India the placebo is like 59 and the Sitagliptin is 119 respectively. And when you take this parameter, the fasting plasma glucose, that is the placebo is 169 versus the Sitagliptin group 339, and in India the placebo is 59 and the Sitagliptin is 119, and you can see the LS mean change from the baseline, that is the least square means, and finally you come to this particular thing where you find the least square mean between the group difference is all countries it is the reduction of the HbA1c is by 1%, whereas in Indian scenario it is reduced by 1.4%, which is a marked difference between the Indian population when compared to the all countries in the world. It is only that our population, they have a better DPP4 inhibition when compared to the whites or the Caucasians. And likewise, when you take the fasting plasma glucose, it was it is given in millimoles actually. The reduction was in all the other countries, it was reduced by 1.7 millimole, and our Indian scenario, it is reduced by 2.2 millimole. So each millimole is around 18.1. That's it, you need to calculate. And the decrease in the fasting plasma glucose in Indian scenario with sitagliptin is around 40 milligram per deciliter, which is very, very significant. So the 77% Indians do not have adequate glucose control, because this is based on the TITE study. And HbA1c reduction with sitagliptin overall was 1%, while in Indians it was 1.4%. And the fasting plasma reduction with sitagliptin overall was 1.7 millimoles per liter, while in Indians it was 2.2 millimoles per liter. That is more than 40% milligram per deciliter. We don't use the millimoles, but in our scenario it is only milligrams per deciliter. Next slide please. So the benefits of the SGLT2 inhibitors in Indian patients. Next slide please. See, the early start of diabetes and the macrovascular complications in Indians. See, the reasons we have already narrated, because it is almost a couple of decades the diabetes starts early in the Indian scenario. Likewise, the complications also go parallel with the start of diabetes. So the funda is now that we need to hit early and hit hard, and the lifestyle modifications, and after that followed by metformin, after that adding one more, that doesn't fetch you at all nowadays. Now the funda is changed. You have to strike it early, strike it hard with the non-pharmacological like diet, exercise, and the reduction in the weight, cessation of alcohol and cessation of smoking. Apart from that, you need to go for a combination therapy. That's it. So to start with itself, you go for a combination therapy. Thereby you control the diabetes early, so that there is a term called a legacy effect. So if you can control the diabetes, well control the diabetes in the first 10 years of one's own life, that is being carried forward throughout the rest of the life of that particular patient. That is called the glycemic legacy effect. So I don't say that after 10 years you leave the patient, you neglect the patient. My intention is not that, but to tell you the glycemic legacy effect, I am telling you, if we can prevent, they want to prevent the complications, you need to be very stringent in the first decade of the diabetes life, very meticulously, so that you can prevent either the micro or the macrovascular complications. And the type 2 diabetes is an independent risk factor for cardiovascular disease. A joint editorial of the statement by the American Diabetes Association and the National Heart, Lung, Blood and Institute and the Juvenile Diabetes Federation International and the American Heart Association in 1999 itself declared diabetes as an independent risk factor for cardiovascular disease. And 1 in 3 patients with diabetes will have early onset of cardiovascular disease. And coming on to the right side, the glycemic control may not have a significant impact on cardiovascular disease, that I have discussed in depth, because the glycemic control is not alone going to control this, because there are multiple risk factors for the occurrence of this particular cardiovascular disease. And the macrovascular complications start developing much early during the pre-diabetes stage. That is the reason I said all the time go for a mass screening, try to pick up the patients at the stage of either impaired fasting glucose or the impaired glucose tolerance are combined put together, which is called the prediabetes, to control the incidence of cardiovascular disease, because the incidence is very similar. This particular cardiovascular disease is very similar in prediabetes and in the over diabetes. So next slide please. Now it's high time we have to talk about the extra glycemic effects, the role beyond A1C reduction. You see, all the time now we have to move from the glucocentric approach to the cardiometabolic renal centric approach. That is the latest funda. The SGLT2s, the inhibitors, have cardiorenal protective effect independent of glycemic levels. The cardioprotective actions, 18% reduction in the cardiovascular death, and the 11% reduction in the MACE, the significant reduction of cardiovascular risk despite background use of cardiovascular medications, and 30% reduction in the hospitalization for heart failure, effective in both the heart failure with preserved ejection fraction, that is HPF, and the heart failure with reduced ejection fraction, that is HPF, as well as the HREF. On the renoprotective actions, the reduction in CKD progression is by 45%, and the renoprotection progressively attenuated as the estimated glomerular filtration declined, indicating greater benefits in early stages. So the SGLT2 inhibitors provide an opportunity for the cardiovascular protection in every diabetic patient, and this is the substantiated by the Sitagliptin is substantiated by the TECO study, which is a cardiovascular outcome, which showed that this particular Sitagliptin is neutral to this particular the cardiovascular disease, so that it can be used very safely, in particular with the cardiovascular disease. So TECOS is with the Sitagliptin, and the Seva-TIMI 58 is with Saxagliptin. And I mind you, Saxagliptin all the time induces heart failure. So whenever you suspect that particular this thing, try to avoid Saxagliptin, please. And you stick to this Sitagliptin, or the best gliptin is linagliptin. But potent wise, when compared to lina, the reductions in the fasting plasma glucose and the reductions in the HbA1c is greater than this particular linagliptin. That is the greatest advantage of the Sitagliptin. So this is the role of Sitagliptin beyond A1C reduction, and the SGLT2 inhibitors provide opportunity for the cardiovascular protection in every diabetic patient. Next slide please. And the SGLT2 inhibitors, they are effective cardiorenal protection seen even in non-diabetic patients. Is this slide something wrong? Because see, we are talking about the DPP4 inhibitors. Torrent people. See, it's about the DPP4 inhibitors, not the SGLT2, because the DPP4 inhibitors are effective in cardiorenal protection seen over even in the non-diabetic patients. Not with the Sitagliptin, certainly. I think they have to change this slide actually, because I was given these slides just prior 10 minutes to the talk, and they asked me to talk about this particular. I never knew that I was the speaker of the evening. There is something wrong, it seems. Now coming to the, one second. Get back to the old slide, please. See, now this slide is with regards to the DPP4, SGLT2 inhibitors. And we are talking about the dapagliflozin, which reduces the cardiovascular death and hospitalization for the heart failure patients in patients with 25% or without diabetes is 27%. That is the reason why this particular the SGLT2 inhibitors are indicated, they are approved for the usage of as well as the patients without diabetes by US FDA, was just because of the tremendous results they have seen in this particular the hospitalization for the heart failure or the heart failure incidence, and the reductions in the all cause mortality and the reductions in the cardiovascular death. So in CKD patients, dapagliflozin significantly reduced 39% decline in the estimated glomerular filtration, the end stage kidney disease, and the death from renal or CV causes. And the dapagliflozin is approved to reduce the risk of cardiovascular death in heart failure patients and heart failure with CKD patients. And the SGLT2 inhibitors can be looked upon as a cardio-reno-protective drug with glycemic benefits. At this particular juncture, I would like to highlight the other aspects which are not mentioned in this slide. They are hepatoprotective also, because the dapagliflozin, especially dapagliflozin and empagliflozin, they have got a very unique role in the cases of non-alcoholic fatty liver disease, NAFLD, from preventing the NAFLD to get into the NASH, non-alcoholic steatohepatitis. And once you cross the state of NASH, once the fibrosis starts and the cirrhosis sets in, no drug is effective, and it eventually progresses onto the hepatocellular carcinoma. So if you can make out this particular, just order one ultrasonogram abdomen for all the patients of this particular type 2 diabetes mellitus. You find either grade 1 or grade 2 or grade 3 fatty liver given by the radiologist. You go for the elastogram, the fibroscan, which is very much available with either the radiologist or the medical gastroenterologist, where they can measure this, whether the patient is in the stage of NAFLD or NASH, so that it's a multi-pronged approach. I don't say that alone SGLT2 is going to help. So the first drug choice will be the pioglitazone, that is at least the 30 to 45 milligram must be used if at all you want to have the benefits on the NAFLD and NASH, along with metformin, along with the SGLT2 inhibitors, along with the DPP4 inhibitors, along with the vitamin E 400 mg BD, along with the statins, along with the fibrates, along with the saroglitazar, and so many drugs. It's a multi-pronged approach, but definitely the SGLT2 inhibitors, the dapagliflozin and empagliflozin, have a wonderful role in the preventing the NAFLD and the NASH, apart from the cardio-renal and all. See, primarily the dapagliflozin emerged as an endocrine domain product where it lowers the blood sugar. Later on, we came to know that that is going to reduce the blood pressure also, significantly the systolic blood pressure, and very non-significantly the diastolic blood pressure. And the nocturnal hypertension is very well tackled by this the SGLT2 inhibitors, because nocturnal hypertension is the deadly cause for the incidence of the cardiovascular disease, either the heart attacks or the strokes in the danger hours, that is 2 to 4 a.m. So thereby SGLT2, along with the standard treatment protocol for nocturnal hypertension, if you add this SGLT2 and the dapagliflozin to the particular the standard treatment of nocturnal hypertension, so it's going to reduce the blood pressure, so that the incidence of CVD is very much reduced. And we have seen that there is a 24-hour blood pressure control with SGLT2 inhibitors. Not only the nocturnal hypertension, not only the daytime hypertension, the morning hypertension and the evening hypertension. the 24-hour BP control is there. And apart from that, the wonderful phenomena, the feature of this particular SGLT2 is the weight reduction, because around 80 to 120 milligrams of glucose is being excreted by the kidneys in 24 hours, and that leads to a significant weight loss. In my clinical practice, I have seen at least 5 to 7 kilograms of weight loss in the 3 months after initiation of this Dapagliflozin actually. And the one more favorable effect of this particular Dapagliflozin and Dapagliflozin is they have a role in decreasing the hyperuricemia also. They reduce the serum uric acid levels. So next slide please. So now coming to the fixed dose combination of Dapagliflozin and Sitagliptin. Next slide please. And this is a classical picture of the ominous octet, the pathophysiology of the type 2 diabetes postulated by my own mentor Ralph Anthony DiFranco actually. So the 8 defects which are at the level of pancreas, the decreased insulin secretion, and at the level of pancreas, increased glucagon secretion, at the level of liver, the increased hepatic glucose production, and at the level of the brain, the dysfunction in the neurotransmitters, and at the level of muscle, the decreased glucose uptake, and at the level of kidney, it is increased glucose reabsorption, and at the level of fat, it is increased lipolysis, and at the level of the blood vessels, this is the decreased incretin effect. And the combination of this Sitagliptin and Dapagliflozin with metformin takes care of 7 out of 8 elements in the ominous octet of the pathophysiology of type 2 diabetes mellitus. What more we want than this? The triple drug combination of Sitagliptin and the Dapagliflozin added to the metformin. So the treatment of type 2 diabetes always starts with non-pharmacological therapy, and metformin is the first drug of choice unless otherwise it is contraindicated. And if it is contraindicated for some reasons, so either the severe gastrointestinal intolerance and all, then you can take it as the Sitagliptin as the first line of molecule along with the combination of Dapagliflozin in case the patient is intolerant to metformin. And the best is the combination of metformin and the combination of FDC of Sitagliptin Dapa to the existing metformin, which is going to address the 7 out of 8 elements of the ominous octet. So except the neurotransmitter dysfunction, which is taken care by the bromocriptin, apart from that, all are being addressed by this combination of Sitagliptin and Dapagliflozin added to metformin. Next slide please. So phase 3 clinical trial on Indian population with Dapagliflozin and Sitagliptin, that is FDC. Next slide please. So a phase 3 prospective randomized double-blind, double-dummy, active controlled comparative parallel group multicentric clinical study to evaluate the efficacy and safety of fixed dose combination of Dapagliflozin plus Sitagliptin tablets in patients with diabetes mellitus, suffering from diabetes mellitus, inadequately controlled on metformin monotherapy. The reason I said now the funda is hit hard, hit early. Don't start with only monotherapy, wait for so much of time, starting with 500 milligram and increasing it to 1000 and 1500 and then to 2000 and then add something else. That is not the funda right now. And the primary efficacy endpoint is mean change in the glycosylated hemoglobin, that is HbA1c from baseline to end of this study visit, that is, this was a study carried over for a period of 16 weeks. And the secondary efficacy endpoints, the mean change in fasting plasma glucose from baseline to end of the study visit, that is week 16. The mean change in 2-hour postprandial plasma glucose from baseline to the end of the study visit, that is week 16. And proportion of the patients achieving the therapeutic glycemic response defined as the HbA1c of less than 7 at the end of the study, that is 16 weeks. Mean change in the body weight from baseline to end of the study, that is end of 16 weeks. Next slide, please. You can very well see in this bar diagram the primary outcome, that is the mean change in the glycosylated hemoglobin, the HbA1c from baseline to the end of the week 16. The fixed dose combination which is given in the brick red, that shows the FDC of Dapagliflozin 10 mg and the Sitagliptin 100 mg has reduced the A1C by 1.54%, whereas Sitagliptin alone 100 mg has reduced it significantly by 0.98% in the hemoglobin, the glycosylated hemoglobin. The mean change in the glycosylated hemoglobin from baseline to the end of the study, that is the 16 weeks, you can clearly see the difference of more than 0.56, the increased reductions in the glycosylated hemoglobins with the FDC of Dapagliflozin 10 mg and Sitagliptin 100 mg versus Sitagliptin 100 mg alone. Next slide, please. And the secondary outcome also, the main change in the fasting plasma glucose and the from baseline to the end of the study, that is week 16. The same thing happens. The reduction in the fasting plasma glucose with the combination of Dapagliflozin 10 plus the FDC of Dapagliflozin and Sitagliptin has reduced the fasting plasma glucose by at least 28.11 milligram per deciliter, and when compared to the Sitagliptin, which is given in the blue bar, has reduced to a tune of 16.69, and the mean change in 2-hour postprandial plasma glucose from baseline to the end of the study, that is week 16, and the mean change in the fasting plasma glucose from baseline to the end of the week 16, you can clearly see that it is the fasting plasma glucose, the 2-hour postprandial glucose is reduced by 54.53 milligram per deciliter with the FDC of the DAPA and the Sita, whereas the Sita alone has reduced the 2-hour post glucose by the 34.88 milligrams per deciliter. So we have seen the primary outcome positively and the secondary outcome very positively. Next slide, please. And the combination therapy of Dapagliflozin and Sitagliptin produced statistically significant reductions in the HbA1c and the fasting plasma glucose and the 2-hour prandial glucose. These three are called the glycemic triad. So with this particular FDC, you can clearly achieve this glycemic triad, the fasting plasma glucose and the 2-hour postprandial glucose and the reductions in the A1C. Next slide, please. And now we come to see the benefits of the combination, the FDC of Sitagliptin and Dapagliflozin. This is a 24-hour glucose control, even better glucose control in Indians, because I have told you both the molecules have got the scientific data, that is evidence-based medicine, and many trials have confirmed that there is a better DPP4 inhibition, there is a better SGLT2 inhibition in the Indian population when compared to the Caucasians or the whites. So the reductions in the A1C, the reductions in the fasting plasma glucose, and the reductions in the 2-hour postprandial glucose is more when compared to the whites and Caucasians when compared to the Indian population. And further better A1C reduction and reductions in the cardiovascular events, that is, you can see it in the 3-point MACE, 4-point MACE and 5-point MACE. And the heart failure or the hospitalization for the heart failure, improvement in the kidney function, and I said already improvement in the liver function also, that is, it prevents the NAFLD from getting into the NASH as far as liver is concerned, and reduces the serum uric acid levels, and thereby it counters the hyperuricemia, which is they see the common the diseases which are they are clubbed is the type 2 diabetes is always associated with the increased incidence of hypothyroidism. Likewise, these two are associated with the increased incidence of gout or hyperuricemia. So reductions in the serum uric acid is a beneficial role of this particular dapagliflozin and the empagliflozin, so that the incidence of gout also goes down with this, and it automatically reduces the pill and bill burden. Wonderful. It's pill and bill burden, and better insulin resistance reduction, and improvement in the beta cell function as well as the insulin sensitivity if it is combined with metformin, an insulin sensitizer. And hopefully I think in the month of October we are going to get this triple drug combination of sitagliptin, dapagliflozin and metformin, and effective and safe in elderly, because elderly patients who tend to get into hypoglycemias and who tend to forget to take the tablets are taking the tablets double time because of the cognitive impairment. So they don't get into the classical, the advantage of this particular the combination of sitagliptin and dapagliflozin is wonderful reductions in the glycemic triad without letting down the patient with incidences of either L1, L2, L3 hypoglycemias, and no risk of hypoglycemia and weight increase. See, sitagliptin is weight neutral. Dapagliflozin certainly reduces the weight by the mechanism of the glucose excretion to a tune of 80 to 120 grams per day, and it reduces the reabsorption of the glucose, and that too that's a wonderful action. So the reduction of glucotoxicity and safe in long run. Next slide please. And before saying a thanks, say I would like to just say one sentence. See, all the time we talked about where it is to be given, which patient is the ideal patient for this particular combination. At the same time, we should say that where it should not be used also, because there are certain contraindications for this particular the SGLT2 inhibitor or the DPP4 inhibitors. Like especially you take this the DPP4 inhibitors whenever the patient is dehydrated. You are not supposed to start this particular the SGLT2 inhibitor. And when the patient has got a recurrent history of urinary tract infections or the candidiasis, that patient becomes unfit for this particular dapagliflozin. And the counseling plays a vital role, because you just tell the patient to get adequately hydrated. When you add this particular dapagliflozin to the patient, ask him to take plenty of fluids, avoid getting into dehydration, and the second thing is maintaining the genitourinary hygiene will reduce the incidence of this genitourinary tract infections or the UTIs or the vulvovaginal candidiasis, or the balanitis or fasciitis or balanopasciitis. And one thing you have to keep in mind is the euglycemic decay, which is sometimes seen with this the patients who are on this SGLT2 inhibitors. Blood sugars will be 140, 150, but the ketones will be present. You have to be cautious with that particular condition. And one more, the common clinical scenario is that the patients who are on gliflozins, the dapagliflozin, and the blood sugar will be, the fasting will be 120 and the post lunch will be 140, 160, but still the urine shows either 3 plus or 4 plus, because glucose is being excreted by the DPP4 into this SGLT2 inhibitors. So you don't need to worry about that. You just tell the patient about all these things. Take 5 minutes to counsel about all the things which I have narrated before initiating this particular this thing. And the foremost important thing as far as the dapagliflozin is concerned, you have to start it very early in the course of type 2 diabetes, because it doesn't yield the benefits like the glycemic control, the benefits in the glycemic triad, the blood pressure reductions and the weight reductions, and the cardiovascular benefits like 3-point MACE, 4-point MACE, 5-point MACE, and the hospitalization for heart failure, and the improvements in the kidney parameters, improvements in the liver parameters will not happen if the duration of the diabetes is very long and you start very late. And sometimes it so happens that you want to have the better results, you have to start very early in the disease course, because sometimes you will not be able to initiate dapagliflozin to some patients where the estimated glomerular filtration rate goes down as per the latest recommendations. The 30 ml per minute, that is confined only to stage 3B. So 4 and 5 you cannot initiate, so that you will not be able to pass on the benefit of this dapagliflozin. If at all you want to pass on the benefit of this particular dapagliflozin, you have to start very, very early in the course to have all the cardio, renal, metabolic and the hepatic complications to be prevented. And as far as SGLT, this DPP4 inhibitor, see, the sitagliptin probably needs a down titration in the diabetic kidney disease. Certainly. See, if the patient is using 100 milligram, if the EGFR is going down, you have to come down to 50 milligram. You don't need to discontinue it. You can come to 25 milligram and still it is acceptable. And any stage of this thing, but ESRD is one stage where you cannot reverse and you cannot have any benefits out of this the DPP4 inhibitors. With that, if there are any questions, I am glad to take the questions. Am I audible? Rajib, are there any questions?